Hi, John Armstrong from Advanced Surgical. There's been a lot of interest recently in the weight loss medications here in Australia and how they're going to fit into weight loss surgery practice like ours at Advanced Surgical. A couple of years ago, Ozempic was all the rage. It was being used to treat diabetes and it was found to have a fairly significant weight loss effect, and it ended up being prescribed off-label for weight loss with a lot of success. People were losing 5 to 10% of their total weight on Ozempic, which is a once a week injection. And then it disappeared off all the shelves as it was used so much, and now it's coming back. And we're starting to prescribe it and be able to prescribe it fairly freely again off-label for weight loss. So what is Ozempic? Well, Ozempic is something called a GLP-1 analog, and it's an injection. It's once a week. It comes in a pen, which I've grabbed my pen. This is the pen. You get it from the local pharmacist, dial up a number, and then you have to inject yourself once a week. It sounds pretty terrible, but actually it's not too painful. It's a tiny little needle, and you end up on a increasing dosage. You start off on a low dose and see how you go for a few weeks. Some people stay on a low dose, others find nothing much happens in terms of weight loss and it's slowly increased. And then there's a maximum dose, and once that's achieved, that's it for weight loss, and people do tend to find 5 to 10% weight loss. So Ozempic actually works by fooling your body into thinking that you've had a meal. When you eat, food goes through your bowel, through the small bowel particularly, and then normally it gets to the end of the small bowel and it's absorbed, and the cells in the lining of the bowel release a hormone. When they sense all this food, they release a hormone really, which goes back through the bloodstream to the brain saying, you've eaten, you're full, don't eat anymore. So it's actually reducing appetite, and that's how it's working, and it's pretty effective. So what's the problem with Ozempic? Well, first of all, it's moderately expensive. In Australia, it's costing $140 a month, which is not as bad as some other medications, but still, we know if you were to stop Ozempic, it's quite common to get fairly rapid weight regain. So many of us think that it's going to be a lifelong requirement to be on these medications. So there's a cost. A fair number of people get nausea. That's probably the biggest issue. And nausea which is pretty difficult to treat. Sometimes in the first week or two, it's really, really bad. Then it gets better, and then people tolerate it and just move on and leave it all behind them. But for other people, it's a real limiter, the nausea. It's also been documented with Ozempic that there's a rare risk of pancreatitis, which can be quite nasty if it occurs, a slightly increased risk of gallstones, and there's a very rare type of thyroid cancer called medullary thyroid cancer, which may be more common in patients on Ozempic. So that's Ozempic really. Next up in terms of medications is Saxenda. And that's a drug which is fairly similar to Ozempic, but unfortunately it has to be given as an injection once a day, which for a lot of people is quite onerous. It's probably as effective as Ozempic. It's more expensive. In Australia it's about $440 a month, so over a year that's almost $6,000. But it's certainly been available over the last few years, and it's been used with the same kind of profile, same sort of safety profile as Ozempic. My preference, obviously on cost and just ease of use, would be to use Ozempic over Saxenda. Similar to Saxenda and Ozempic, we'll be hopefully seeing, and I think it won't be till 2024, two new medications which have been out in the States for the last year and a half called Wegovy and Mounjaro. They are similar, they're GLP-1 analogs. They're given once a week. They're quite expensive. Wegovy is almost identical to Ozempic, but it's 3 times the strength ultimately. And in clinical trials in the US, people are losing 15% of their weight, which is actually pretty significant weight loss. Same kind of profile, issues with nausea, once a week injections. Cost has been an issue with the $10,000 US a year that it's costing over there. I don't think it'll be $10,000 a year when it's in Australia, but it'll probably be more expensive than Ozempic. The main issues with Wegovy and Mounjaro is we just really don't know when they're going to come into Australia. I think with the success they've had in the US, they're building up their supplies and stocks there, and then they're releasing it in several countries slowly so they don't run out when it is released. Because I think it will be something that we will use a lot of if it isn't too expensive, but not until 2024. There's another type of medication I'd like to discuss, and that's an oral medication, and it's called Contrave, and we do use it occasionally. It's a combination of 2 medications bupropion and naltrexone. One is a mild antidepressant, and the other is it's actually used to treat addiction for opioid and alcohol addiction with some success. The combination works well for some patients, and they can lose up to 5 and sometimes 10% of their total weight. It is about $250 a month. There are some issues with nausea and vomiting and constipation, and there have been some mental health issues such as suicidal ideation. For myself, it's a second line medications after the GLP-1 analogues that we previously discussed. So how do we see these medications fitting in with a practice such as advanced surgical? I think they're very useful adjuncts. We have been asked, are we worried that we'll be out of a job? Will we not doing any operating on patients because everyone will lose so much weight on these medications? I don't think that's the case at all. I think they're a really useful adjunct. I think we should embrace them. I think some people will do extremely well and they won't need an operation, which is great. I think they're really good to try for low BMI patients. If someone has a BMI of perhaps 30 to 33 range, and perhaps we don't want to look at a significant operation such as a sleeve gastrectomy, we may find that we're using Ozempic or maybe next year Wegovy, and they have really significant weight loss and never need an operation, and that's fine. So we'll certainly be trialing patients on it if they haven't already used them. The next line of usage I think will be in the pre-op stage for patients. So we have some fairly large patients who would historically be on Optifast for 2 to 4 weeks to lose a bit of weight before an operation, perhaps get rid of their fatty liver issues, and it may be that we can use Ozempic or Wegovy next year to speed up that weight loss and make them safer for an operation in the first place. Then we might also consider using particularly the GLP-1 analogues such as Ozempic in the post-operative phase. There have been some studies from the States where they've had these stronger medications such as Wegovy for over a year, and they're seeing better overall weight loss in the first year after surgery. And we know the first year is super important because most patients, particularly with a sleeve gastrectomy, will lose the weight they're going to lose in the first year. So if we can accelerate that weight loss and their lower point is 10 kilos perhaps lower, then that's excellent news for them. It'll reduce their comorbidities, it'll reduce their diabetes and their joint loading, and it will be very helpful for them. So I certainly think that'll be something we'll use more of, and we already are now using that with Ozempic. It is possible we may also use medications like Ozempic in the maintenance phase. We know that patients will lose weight for a year, generally plateau, hopefully for at least 5 years, particularly after a sleeve gastrectomy. And some patients who've been successful on Ozempic may want to continue on a low dose just to make sure that they keep that weight off for the foreseeable future. We'll certainly be using it for weight regain. We know that that's an issue with any operation that anyone's ever done for weight loss surgery. Once you get out to 5 and certainly 10 years, there'll be a group of people that battle weight regain despite their best attempts. And I certainly think that would be very useful for them, particularly if they've had, say, a sleeve gastrectomy. It saves them from requiring revisional surgery such as gastric bypass. We also could use it for reflux in that setting too, because we know that some patients who've had a sleeve perhaps years ago, they're putting on some weight and they're starting to get reflux, perhaps because there's more abdominal pressure with their weight regain, and it might be worth using the weight loss medications to reduce their weight and hopefully reduce their reflux as well. So just to summarize then, these are very useful adjuncts to weight loss surgery, and they may actually prevent some people from having operations in the first place. I guess my concern with the medications is that some of them are expensive. We don't know how expensive the new GLP-1 analogues will be when they arrive in Australia. And we also know that when people stop these medications, they are likely to get fairly rapid weight regain. So really, they're going to have to be used probably lifelong. But I think we'll just have to wait and see how that pans out, really. But we're certainly happy to have discussions with patients here at Advanced Surgical about how to use these medications in combination with their surgery. And I hope that answers some of your questions about these medications.